Hello and welcome to the last of the CPD sessions that we did at the end of 2024. Just to let you know, this is a re-recording of that session. It's not the actual live session, unfortunately. I've got to record it at the time, but hopefully this recorded session will give you an idea of the credentialing framework and the work that's going to be happening this year. I just thought we'd revisit the current model of care across Aotearoa, New Zealand, and this is currently what our model of care is for diabetes foot care, which focuses on prevention, early detection and management of foot complications. The quality standards for diabetes care states that all people with diabetes will be regularly assessed at least annually for the risk of foot ulceration and will be documented using national guidelines. If required, they will be referred for podiatry review and treatment. Those with active foot problems will be referred to and treated by a specialist multidisciplinary foot care team within recommended time frames. So as you can see from this model, an awful lot, or the vast majority of people with diabetes, when they've had a foot risk, will be mainly assessed as being at that low risk. So all patients under the current model should be seen or have their feet screened at least annually, and this is generally done in the private primary care setting by either their GP or practice nurse, or sometimes healthcare assistants working in the practice. A lot of those patients just need education and don't necessarily need to be seen by podiatrists at that level. At the next level, anybody who's been assessed as having an at-risk or high-risk foot problem would be hopefully referred through to the community-based podiatry services, and in the northern region this is those community podiatrists who hold contracts with the 7 primary health organisations, or PHOs. Anyone with an active foot problem that's identified at practice level, or may be identified whilst being seen under the community-based podiatry programme, should be referred through to the secondary high-risk foot teams, where they can be seen by the multidisciplinary team and specialist podiatry services. Anybody who has acute foot disease with further complications, maybe infection or ischemia, can also be referred through to the secondary higher risk vascular services if they need particular intervention. As you can see from this model, there is a slight overlap between services, because there's also that in remission group of patients who are really high risk and frequently maybe need to be seen more often than can be accommodated within the community-based podiatry services. So they may be seen at that secondary care level under specialist podiatry services. Throughout all of these levels, an awful lot of patient education is really important. Education on foot care is crucial. Patients are advised on daily self-checks, proper foot care, and hopefully when to seek medical help if they do have an urgent or active foot problem. These pathways ensure that patients receive continuous and coordinated care from primary care settings through to specialised foot clinics. Special considerations for Maori and Pacific people should be given the higher incidence of diabetes-related foot complications in these populations. Tailored interventions and culturally appropriate care is really important and emphasised. Just wanted to reiterate the importance of diabetic foot care. We all know that the main causes of amputation include diabetic foot ulcers, infections and ischemia. Many amputations are preventable with adequate podiatry care, yet 65% of those who underwent amputations had not accessed specialist podiatry services before their first amputation. So we know that we're missing out on an awful lot of those patients who do need care and should be able to access care and not currently accessing that care. The main causes of amputation include diabetic foot ulcers, infections and ischemia. The focus is on prevention of active ulceration by being able to identify those at higher risk in primary care and nursing that those at highest identified risk are receiving podiatry care at primary care level. Part of this care is funded through the PHO, but patients can also opt for private podiatry if they're able. Practice nurses and GPs also should be providing foot screening and foot checks for those at high risk at every presentation or opportunity, and for those at the lower risk end of this scale at least annually. Just wanted to mention again inequities that we're all aware that exist within healthcare, and especially for our diabetes population and for those with active foot ulcerations, and the importance of tetility or Waitangi, which those principles should ensure that all people across all services have equal access to care and are being referred within a timely manner to appropriate services. We already know that there's inequities that exist specifically in health, education, Department of Justice, corrections, particularly affecting Māori and Pacific Island populations. So we know that there's higher rates of diabetes and higher levels of socioeconomic deprivation, which can reduce access to healthcare, can result in delays in diagnosis, reduce prescription and prescribing rates to current treatments, or sometimes it can mean that people aren't what's called treat to target. So they may be on an appropriate medication, but those medications haven't been titrated up to an appropriate therapeutic level where they're actually doing what they're supposed to do. Amputation rates for Māori and Pacific individuals experience higher rates of diabetes-related lower extremity amputations, and for Māori we know that it's 65% more likely than non-Māori to require amputation. These groups also tend to undergo amputations approximately a decade earlier than other populations. Mortality post-amputation are higher and usually occur at an earlier age. Levels of peripheral arterial disease and gout have increased rates, and again due to above issues, less likely to be prescribed medication or be treat to target. There's also a stigma around gout within certain communities around the cause of gout, and we know that certain ethnicities are more predisposed to developing gout. In relation to access to service or service availability, we know that certain communities often encounter barriers to accessing high quality podiatry services, including those that live in remote or geographically remote locations, if there's cultural differences, and also due to systemic racism. These barriers continue to contribute and result in delays to preventative care. Despite available funding for diabetes podiatry services, there's still a fragmented healthcare system and inconsistent implementation of culturally appropriate care exacerbate those disparities within those communities. So I think a few years ago we actually looked at some of those services, and a review of Auckland and Waitemata services across the region highlighted that there was some gaps in service. So some of those contract requirements have been changed and put in place, but some issues were actually identified where there was no adherence to the contract requirements, even though those had been agreed. There was some issues, for example, podiatrists working without current annual practice and certificates, podiatrists that were non-e-referral enabled, leading to high-risk foot services or patients missing out on referral to high-risk foot services, or delays happening to first appointment due to the amount of time that it had taken for referrals to get through to the appropriate places. Businesses not having access to basic required equipment or having some equipment and not other equipment. So there was inequity across the region of what equipment podiatrists had access to. There was differences within timeframes, that appointment timeframes. So it meant that it was causing pressure on certain podiatrists to try and complete full assessments within limited time periods, which was making it really difficult. And sometimes there was lack of communication between community podiatrists and GP practices. I think, just to reiterate, because the credentialing framework came out of a lot of work that's been done over the past kind of 5-6 years, possibly longer. But I think some of these areas are the ones that we want to try and focus on. The main reason for having the credentialing framework and the standards across the northern region is to try and make sure that patients do have equitable access to services, that all people are eligible individuals are receiving necessary podiatry care, that there is a focus on Māori and Pacific health because of those inequities that we know that exist for those community populations, that there's support for self-management, so that as podiatrists we're able to accurately signpost people to support services that's culturally appropriate if they need it, that we can start and try and have an impact and reduce unnecessarily hospital admissions, that we're actually capturing those things and seeing people early enough and they're getting quality of care and the appropriate information and education to make sure that they can continue managing their foot health needs appropriately, and also increasing ulcer-free days. Again, just enhancing that patient quality of life by increasing days without ulcers. So it's some of the reasons why we need quality services across diabetes foot care services across the region, just to make sure that those services are appropriate and we're all providing a really good standard of care, and that there's no kind of inequity that exists across those services, that we're all know that what we're trying to provide and what those quality services look like. So again, just to reiterate the reason for the credentialing framework for podiatry services, and the main aim of the credentialing framework is to ensure that anyone that holds a contract with the PHOs are fully supported and aware of what those contract requirements are and what the standards of practice are and what is required to provide that kind of service, so that all podiatrists are working to the same standards, are competent to provide safe, high quality standardised care to people with diabetes, and we're ensuring that contracted podiatrists are aware of the requirements and standards. This is linked, the credentialing framework is also linked to the Metro Auckland standards, which sets out what the requirements are, what an appropriate quality service should be providing. The Metro Auckland Foot Screening and Community Protection Service Standards 2019 set out what standards are required, and the credentialing framework is just a support framework to ensure that these standards are, or those requirements are actually being put into practice. It's kind of oversight and clinical governance of services. It's also a way of improving quality of standards and being able to identify common areas of educational needs across the region, so we can identify as professional leads if there are educational needs for community or commonality for community podiatrists, that we ensure that we're providing that kind of support that may be needed. So just to go over some of what the contract requirements are and qualifications. So these are the essential things that contracted podiatry services with PHOs should have in place. So all podiatrists providing care obviously should have a Bachelor of Health Science in Podiatry or equivalent. They should all have a current annual practicing certificate. They should all have a minimum of 18 months to 2 years of experience in diabetic foot care, which is essential. However, if you do have a member of staff in a larger team that doesn't have that level of experience, that obviously those people are being supervised, or you've got some kind of mentorship program in place, would helps to educate and bring that person up to speed. But obviously they need to have appropriate supervision and other support structures in place. That there's access to necessary equipment for conducting comprehensive assessments, and that's one of the mandatory requirements, so that obviously if somebody does need an in-depth chairside vascular assessment, that you do have the ability and the knowledge and skills to be able to do that and complete that. That people do have access to appropriate referral management systems, and specifically e-referral, so that you are e-referral enabled. It doesn't necessarily have to be every single person in the practice, but it could be the main practice lead that's e-referral enabled, and that other members of staff can send e-referrals for patients to high-risk foot clinics utilising that system. That there's effective communication with referrers regarding assessments, specifically first patient assessments, if the patient doesn't turn up, if the person's being discharged, that, you know, communication with your GP and your primary care services are being kept up to date with what's happening with that patient's care. So these are some of the essential requirements for holding a contract for high-risk podiatry services. So just to explain a little bit around the Credentialling Framework, hopefully you've all managed to see a copy of the Credentialling Framework and what those requirements are and what that framework actually looks like. So there's two different sections. There's actually a business section and an individual podiatrist section, and some of those requirements are may look similar across the business and the individual section. It just means for those larger businesses where you've got several podiatrists working for the under the one practice, that not only the business manager or owner, but also the individual podiatrists as well, also have professional accountability for the service that they are providing. So the business section includes sections 1 to 13, and they should be ensuring that there's compliance and a signed declaration and documented evidence, meaning that they're meeting all of those requirements. Some of the sections, particularly B1 and B7, there was an agreement that across the PHOs that rather than having to check all of those things, that those sections specifically would be checked on an annual basis. And it was more of a high trust model in that a declaration would be sent out to the business owner, and that they would basically sign to say that they are compliant with those particular sections. The other sections, B8 to B13, means that there needs to be some documented evidence, and this can be done through a variety of different ways. It could be by doing an on-site visit, or by just looking over and ensuring that there's specific policies and procedures in place. That means that there's evidence to say that those sections are or the business is meeting those kind of criteria. The second part of the Credentialling Framework is the individual podiatry section, and it covers requirements P1 to P7, ensuring that each practitioner within that practice is aware of what the requirements are and is meeting those necessary standards to be able to provide care to people with diabetes at that high or moderate risk. Again, a lot of the evidence for those requirements can be covered by either documented evidence, doing on-site visits and catching up with podiatrists specifically, ensuring that equipment is in place, that people are competent and confident to use it, or carrying out vascular or neurovascular assessments, making sure that they're aware of that there's consistency around you using the risk assessment tool for NZSSD. Basically, that there's just consistency across the board around podiatrists' knowledge and understanding of what's required to complete care for people with diabetes at that moderate or high risk. Because we're aware that some businesses hold multiple contracts with multiple PHOs, there's an understanding and agreement across the PHOs that if we undergo this process with a podiatry practice, that information will be shared. So if we go and see one practice, but they hold, say, 3 PHO contracts, that the information on the outcome and the results of that visit will be shared with the 3 different PHOs. And it's just to try and cut down on reiterate or duplication of any kind of work that we're doing, to make sure that you know, standards are similar across the board, but also that the PHOs are kept informed around any kind of issues that are picked up, or also to highlight the great work that community podiatrists are actually doing across the services. So I think some of you are already hold ACC contracts, and some of you may have already been audited to the ACC requirements for physio, hand therapy and podiatry. And there will be some sections across the credentialing framework where there's a duplication or very similar requirements needed for these, as well as the credentialing framework. So an awful lot of work when developing the credentialing framework was put in, and it was highlighted where some of those requirements do duplicate the ACC contract. It means that if you do hold an ACC contract and you have been audited to those standards, that actually we can quite easily sign those requirements off, because we've got evidence that you've passed that ACC contract, or you're compliant up to those levels. It may be the same with Podiatry New Zealand Clinic Handbook. If you've already been, if your practice has already been audited and you've passed that audit and you're already meeting those standards, that some of those standards can be automatically signed off. Because the credentialing framework specifically looking at diabetes care and lower limb diabetes podiatry care, there's an awful lot of the things that's within that credentialing framework that's quite specific to providing podiatry service for those people with diabetes, moderate or high risk feet. So although you may be ACC audited and you've passed that quite well, we can't just say that everything that we feel is required or covered in the credentialing framework's being actually signed off. So there is some things that will still need to be evidenced that you're meeting those kind of requirements. So just a little bit around the credentialing framework process and how that's going to actually work. I just want to say a big shout out. Last year we did a trial with 2 businesses just to try the process out, to make sure it worked, like the process makes sense. We're that we've got appropriate timelines that are achievable, that we're not putting undue stress and pressure on people to get things or collect data or information and evidence within an appropriate time frame. I will pass on the details of those 2 people who trialled that as well, because they've both said that they're more than happy to be contacted if people are struggling or they just want to have a little chat about the process or how they found it, or any information about what documentation or evidence was submitted to ensure they were meeting a certain requirement. So for 2025, we're going to semi-randomly select 2 to 3 podiatry businesses to go through this process. That obviously will be in collaboration with the existing 7 PHOs. We will be sending an email out at the beginning of 2025 just to inform those that have been selectively chosen to undergo the Credentialling Framework process, with more further information around, expected time dates, booking in times for visits. We will need access to patient information on patient notes, those kind of things. So in that email, it will also include suggestions of documentation that can be sent through prior to the on-site visit. We just found with the trial period that actually sending through documentation prior cuts down on the significantly on the on-site visit time. Because obviously I realise that you're all very busy clinicians and you all have fully booked clinics and seeing patients, and obviously that's your priority. So we just don't really want to take up as little time as possible, really. We will try and organise a mutually convenient time and day when we can come out to do an on-site visit. So that's generally to meet up with the business owner, and depending on the size of the business, a couple of the podiatrists as well that actually work for that business. If you are a sole practitioner, then obviously it would only be the business owner. So the purpose of that on-site visit is to make sure, or to identify where the requirements are currently being met and where there may be some gaps that you need support with, or education training, or where we can share resources across the region to ensure that all people and all patients accessing diabetes foot services have equal access to equal resources. Any reports, obviously all that information needs to be collated, and then a report will be sent back to the business with the findings of hopefully where you've met those requirements, and any areas where there may be some gaps or areas where you're not quite meeting those requirements, and then we'll work with you to ensure that, where those gaps in services may currently exist, that we can put plans in place to improve. If there's certain areas that need to be looked at or reviewed, and there's plans put in place to improve certain areas, then again there will be a re-review period where we will there'd be agreed time frame for changes to be put in place, and then we would come back in, re-review, look at whether that the changes that have been made means that you're now meeting those certain requirements. So this is just an estimation of the timeline for 2025. I'm hoping to start, we were hoping to start in January, more like February now, but we'll get that email out, and then there'll be approximately 12 weeks for people to gather documented evidence and send that evidence through to professional leads for review. We'll organise a pre-arranged site visit with the business owner and any podiatry staff to come out and meet you. We're also going to ask for a certain percentage of NHIs from the PHOs, so we can review any patient information or patient records. Just to, there's an awful lot of the Credentialling Framework requirements that can be covered by looking at things like patient records or patient appointment patient appointments and what was documented occurred at that appointment. Credentialling Framework report will be completed and then sent out to podiatry business owners. And obviously at that point, if there's anything that you feel has been missed, or further evidence that you feel wasn't given at the time, or anything at all, more than happy to work in collaboration with the business owners to see what plans can be put in place to address any kind of areas where those requirements may not be met. Once there's agreement of that outcome and review, then those plans and information, documentation, everything will be sent through to all the PHOs and will be held centrally on a secure site where the PHOs that have contracts with those specific providers are able to access that information. So I just wanted to highlight a recent HDC case which highlighted some issues within health services previously, particularly up in Northland, with a woman's rights to appropriate care for diabetes breached by Health New Zealand to Tai Tokoro. If you're not aware of this HDC event or complaint, it'd be really good to have a little read through it. They are available on the HDC website. And I think it quite nicely highlights why the things like the standards and the credentialing framework are really important. A lot of those areas that were highlighted, some of the problems was awareness of referral pathways with both primary care at GP level and also with podiatrists that may not be fully aware of direct referral to the high-risk foot clinics. Just ensuring that there's oversight and clinical governance of the services, again, so we can ensure that there's some quality of care across those services, that it doesn't really matter where the patient attends, they should be getting the same level and same quality of care provided. That there's some clear referral processes and systems in place, and obviously if you're quite new to holding a contract with PHOs, that you're fully aware of what the referral processes are and expectations within those systems, where to refer, who to refer to and how to refer, and that there's clear communication between services. That we know that often there's gaps within services, and this services within New Zealand can be quite fragmented at times, but just to make sure that communication is happening frequently with GPs at primary care level, that they're fully aware of where that patient is within their journey. If you've referred them on to high risk foot services, that the GPs, letters are going back to the GPs to make them aware that that's actually happened and those referrals have happened. Some of the other issues that were brought up in that HDC commission case was around terminology and use of the NZSSD diabetic foot risk stratification guidance, and I think generally most people are aware of that risk stratification system, but it's just to ensure that obviously everyone is aware of it, and that we're all kind of risk classifying people around about the same level. I think there's always going to be some interpretation differences and slight differences, but really if people have got active foot ulceration, they should be getting referred through to the appropriate pathways, and just to make sure that everyone's aware, we're all on the same page, and that it doesn't matter where the patient attends for care, that they're all getting a really high quality care provided of equal high standards. So I think just to end the session, to reiterate that the credentialing framework isn't anything really to worry about. All the things that's in the credentialing framework are requirements that's been in place for quite a long time so far. So all of these things should be things that's already happening within your practices and that you should be doing within your practices. It's just a case of having to demonstrate it really now or provide evidence that that is the case and that's what's happening. If there is any areas where it looks like you're not actually meeting those requirements, it's working together with us to make sure that we can fully support you and look at what could be put in place and actually collaboratively sharing information across the region just to make sure that all those people with diabetes are receiving adequate and appropriate quality care. If you do have any questions, you can always contact myself or Michelle Garrett, the other professional lead across the Northern region. And if you find yourself that you have been selected for Credentialling Framework, if you feel a little bit unsure and you'd like to just reach out and contact the 2 people that were involved in the trial, they don't mind at all if you contact them, preferably by email, because obviously bearing in mind they're both clinicians and they're both very busy as well with their own private practices. But I'm sure they wouldn't mind answering some questions if you have any questions at all. I just want to say thanks very much for taking the time to watch this session, and I look forward to working with you in 2025.